The following presentation, entitled Development of Practice-Based Research Networks, was given by Jim Werner, Ph.D., on September 4, 2008, as part of the 2008 Practice-Based Research Seminar Series at Case Western Reserve University in Cleveland, Ohio.
Welcome to the Practice-Based Research Network Seminar Series, sponsored by the Cleveland Clinical and Translational Science Award, CTSA. I'm Jim Werner, and I will be your MC for the festivities this evening. Kurt Stange is out of town and is not able to be here. He spoke last week as well, and he's one of the seminar leaders for this particular series. So tonight, I will be talking about the development of practice-based research networks. But first, I will do a little bit of a review from last week, just to refresh those of you who were here and have had a long day, may not remember, and for those of you who weren't able to be here. So last week, talked about what are PBRNs, why are they useful, what's their history, what types of research do they conduct, and I didn't get to very much about what challenges PBRNs face, and we'll talk a little bit more about that today. So very quickly, a PBRN is simply a group of community-based practices and the clinicians who work in those practices that are principally devoted to patient care, but who affiliate together to do research, to study questions that are relevant to them and their work in clinical practice. And participation in these networks is typically voluntary. Oftentimes these clinicians will partner with academics who have expertise in research methods and professional organizations sometimes who can provide financial support to PBRNs. Organizations such as the American Academy of Family Physicians and the American Academy of Pediatrics and those types of organizations sponsor PBRNs. And because clinical practice is the subject of practice-based research and the place where practice-based research is conducted, in theory, practice-based research studies produce findings that are generalizable, transportable, and more readily translated back into practice after the findings are determined than research that's generated elsewhere in other settings. And we talked about this diagram and how that's relevant to translation, the translation of research into practice. And I won't walk through all these boxes, but the take-home message is that in a community of 1,000 people in any given month, about 217 will visit a community-based physician's office, but fewer than one of those individuals will be hospitalized in an academic medical center. Most of what we know about health and medicine has been derived from academic medical centers where we have a very specialized patient population. A lot less research has been done at the community level. And so it's no wonder that research findings that are generated in the tertiary care center don't translate very well back into the community-based setting because the patients are so different. So the take-home message is that it's also important to study health and healthcare events and medicine and the delivery of healthcare in the community-based setting. So the axiom that you may remember is practice-based research takes place where most of the people get most of their care most of the time. So another point from last week is that the clinical research process for practice-based research as much as it is for all clinical research, identifying knowledge gaps, designing studies, analyzing, translating research back into practice. But what's different about practice-based research is that practices and community-based clinicians provide real input in all of these steps, for all of these steps. So they're incredibly important in identifying knowledge gaps, generating and clarifying what study questions should be. Of course, they collect data. They're essential to the interpretation of findings and then translating research back into practice. So they participate in all of those steps. And without them, research would certainly lack a lot of the depth and a lot of the ability to basically address questions that are really relevant to practice today. And that's what practice-based research networks really seek to do. So this week's agenda is to talk about a little bit more about the characteristics of PBRNs, how they start, what are the components and costs of developing a PBRN. It's a question that is often asked. And then how is research facilitated in PBRNs? So PBRNs can be practice-based research, I should say, can be conducted at the national level. There are binational PBRNs between the U.S. and Canada. I used to be a research director for Aspen, which was a binational network. A lot of state academies sponsor PBRNs. There are regional networks, such as our own Research Association of Practices, which is in 17 counties in Northeast Ohio. Right here, also in the Cleveland area, we have the Safety Net Providers Strategic Alliance Practice-Based Research Network, which is located within the city of Cleveland, 6 different community health centers and free clinics that have done some really good research, but are, by design, they want to study the health issues of patients in Cleveland. Outside North America, we talked about a little bit last week about how network research and sentinel practices were started in the UK and the Netherlands. There are now PBRNs in many countries around the world, and there are consortiums of networks, such as the Federation of PBRNs, that brings different practice-based research networks together so that networks can collaborate across networks, so that you don't just have tens of practices or hundreds of practices, but sometimes thousands of practices that come together and collaborate on really large studies. So a PBRN can be a small number of practices, say 15 or 20, or it can be hundreds of practices. Some PBRNs are just in single specialties, but many of the primary care PBRNs are multi-specialty, internal medicine, family medicine, and they oftentimes include nurse practitioners and physician assistants. Here locally, we have networks in family medicine, pediatrics, advanced practice nursing, dentistry, oncology, and other networks that I'll talk about a little bit later. So there are affiliations, as I mentioned earlier, for PBRNs, national academies, state academies. Academic institutions like RAP are affiliated with CASE and get infrastructure funding from CASE. There are also electronic health records-based practice-based research networks. The first one of those, I think, was Practice Partner, and there are others that simply do studies through the electronic health record. And now, I think a more recent development that we've seen are health systems really seeing the value of doing practice-based research, of seeing pay-for-performance coming down the line, really having an interest in quality improvement, developing systematic methods and the systematic know-how on the part of their practices, staff, and clinicians to be able to do research and do things in a systematic way to improve the quality of care. And so they're developing PBRNs, the Cleveland Clinic being one of those PBRNs in Cleveland that's developed a network. Well, talk a little bit about how PBRNs start. Sometimes they start with an individual or a small group of people having, as we say, a bee in the bonnet, or a certain mission or a certain passion for some specific line of inquiry or question that they really want to study. And so they're really the driving force behind gathering others together, perhaps partnering with academics, and pulling a group together to do a study that starts a PBRN. Some have just a single, very focused question or study idea that they've been wanting to study for a long time. Others have just found knowledge gaps that are frustrating. Clinicians see something coming up in practice again and again and realize that unless I do something about this, perhaps nothing will get done about this particular problem. And so they bring together others who share perhaps that same frustration or that same interest and do something in the form of developing a research project that then ultimately becomes an ongoing organization that's a PBRN. Some of the early PBRNs were also developed just simply because clinicians believed that they really did get a great deal of insight from full-time clinical practice, seeing hundreds and thousands of patients, and all those visits and the wisdom and insight that they gained, they felt was not being fed back into the research process, that they weren't being heard, that all that they were learning was in their own heads but wasn't being shared with others. And so they wanted to find a way to do that. And also the belief that I think early on in PBRNs in the 70s and 80s, there was also sort of a countercultural component to it, sort of in primary care, doing something that was kind of counter to the medical establishment. Family docs and primary care docs felt that they weren't being respected or heard, and so they wanted to do something about that and generate a science base for their own discipline, not something that was derived from specialties. And as I mentioned, electronic health record systems. There are also PBRNs. We have one here in Cleveland that is teaching-based or residencies who have come together to develop a practice-based research network, and we're seeing more of that across the country. There's a national family medicine residency PBRN, for example, where residents learn to do research as a part of learning to do clinical practice. And then finally, health systems having more long-term vision, which I've already talked about. So we'll shift now into talking a little bit about the infrastructure of networks. And I think it's true of most, if not all, PBRNs that really the mission of the network really determines what the infrastructure needs to be, what those elements of the network need to be to make that research happen. And so mission statements are important in networks. The mission provides a vision, and the vision then really determines the scope of work that's done, and to be able to do that, you need to have some infrastructure. So it really, in many ways, does stem from the mission statement. So I have 3 mission statements here that I put together, I found from PBRNs. One being from the Ambulatory Sentinel Practice Network, which was a binational network. And their mission was to contribute to the science base of primary care by conducting PBRN research in the U.S. and Canada and disseminating findings. The second mission statement is from our Safety Net Providers Network, which is to conduct research that investigates issues important to the health of low-income patients who obtain care at Safety Net practices in Cleveland. The third mission being from the Oklahoma PBRN, OKPRN, which has a little bit of a different mission. And their mission is to provide community physicians with access to information, education, research, and technology in ways that enhance their practices and generate new knowledge through practice-based research. So it's really kind of a 2-part mission, and I'll talk more about this a little bit later. This is something I'm seeing more in practice-based research. So the first is really to be of service to the practices in the network, and the second is to generate new knowledge through practice-based research. Whereas the first 2 missions really have as their objective to do research, to contribute to the science base as the primary mission, and we don't really see that other component evident in their mission statements. So I had this slide up last week, and I'll just touch on it again. The infrastructure requirements that were set forth by AHRQ, which is probably the biggest funder of practice-based research, is that to have a PBRN, an organization must meet these requirements. At least 15 practices and or clinicians, a statement of mission or purpose, a director, a support staff, some mechanism for soliciting feedback, an organizational structure that transcends any single study, so just a group of practices coming together to do one study is not a PBRN, and then processes for communication. So common infrastructure elements that you see in networks are a network director is a common element in every network I've ever seen. And this is really kind of the go-to person. Sometimes this is shared as well between, say, 2 people. Sometimes a clinician and an academic investigator will share this role. But these are sort of the go-to people who really kind of make things happen in the network. And although the next component was not a required component by AHRQ, I also have seen this in every PBRN, and that is some kind of a steering committee, advisory committee, or board of directors that really governs the network and oversees the network and typically makes decisions about which studies are conducted in the network, what kinds of things happen in the network, what kinds of things aren't going to be studied in the network. So network directors rely on these bodies to help them make decisions and to also share the responsibility for those decisions that are made, which is also a very useful and important function that these serve, so that the network director doesn't sort of bear the brunt of an unhappy investigator who isn't able to get their study conducted, but it's really a decision made by many people who are part of the network. Network coordinators are really essential to networks as well, coordinating all kinds of functions, communications, membership, also doing a lot of research assistant tasks. Research assistants for networks that can afford them basically implement research protocols, as you might expect, support staff do administrative work. It's also pretty essential to have access to design and data analysis expertise if the director or other members of the staff don't have that expertise. Membership databases, of course, are important, keeping tabs on who's in the network, who's not in the network. And usually there is a common set of elements that are collected from every practice and clinician that's a member of the network, so that for grant proposals and other purposes, the network can be adequately described. So some of these are certainly demographics, payer mix, electronic health records, whether or not those are present in practices, how many have them, how many don't, perhaps different patient populations for major diseases like prevalence of diabetes or heart disease or hypertension, et cetera. And then, of course, there's a a one-way news sharing mechanism that's important, so newsletters and websites, and then also two-way interactions. Listservs are very commonly used in PBRNs and are great ways, in the past at least, to stimulate discussion with clinicians becoming so busy these days. I don't see listservs being quite as useful as they used to be. And web forums are nice too, but you need to log on to a website typically. So listservs are sometimes a little easier for people to use. And most networks also have a membership meeting, typically at least annually, where all the members of the network can come together, talk about research ideas, learn about the findings that have been derived from studies that have been conducted over the past year, and think about what's going to happen in the next year. And it's really, oftentimes, really great synergy takes place between clinicians and academics and others that attend these meetings, and they can be really a lot of fun and very intellectually stimulating too. So people are often interested in the costs of operating a network. So it was nice that in 2005 this article was published to provide some information about that. And these authors are very experienced in practice-based research, and so they really divided this into two columns here. A basic network being a small local network, say 15 to 20 practices doing simple observational studies. And for that network, what they felt would be adequate was as a 20% director, usually a physician, a coordinator at half-time, and those being the only staff members who are paid in the network. And then there are some hardware, computers, and technical support, telephone, fax, etc., and then an annual meeting, for a total cost annually of about $70,000 of infrastructure costs for a small, simple network like that. Now, costs can vary a great deal, and different networks do things differently, of course. And then a moderate complexity network would be, say, a regional network that may, say, have 20 to 60 practices in it conducting intervention studies, more complex studies. And for this network, they recommended a network director of at about half-time, a full-time coordinator, 2 full-time research assistants, a half-time administrative assistant, some other infrastructure costs, and meeting costs of about $17,000, significantly more, but meetings continue to be very important, for a total infrastructure cost of about $287,000, which is a significant amount of money, especially given that it's hard to get these kind of costs covered on research grants. So this can be pretty challenging. But networks do more with less, and by no means is this a requirement for what networks need to have. So there are ways to adjust to this, and many networks sort of ebb and flow, and that's sort of been the history of practice-based research over the years, as grant cycles are somewhat hard on practice-based research networks for this reason. And I'll talk a little bit about infrastructure funding and how infrastructure can be funded in other ways a little bit later. So next I'll talk about organizational models for networks. So this somewhat chaotic diagram is just simply an organizational model for a typical PBRN. So what we have in the black box rectangle outlining diagram is, say, a geography that the PBRN operates within. The circles of different sizes are different size practices that are in the network. And these different size practices may be members of health systems, or they may be independent practices. But typically the way PBRN offices relate to practices is just simply as individual practices. So it's a fairly uncomplicated relationship. It's the PBRN office and the individual practice relating to one another. Another model that has emerged in about the last 7 or 8 years is the peas in a pod model that was developed in the Oklahoma PBRN. And one that we're trying to apply here in Cleveland, have just begun to work in this direction. And so what they have is they have their office, but then they have 8 or 10 practices that form a pod, and then they have these individuals called practice enhancement assistants, or Ps. And I know it's a little too cutesy, the peas in a pod, but the Ps work with a pod of 8 to 10 practices at any given time. And within these pods, they do quality improvement work, they act as research assistants, and they try to meet the needs of the practices and whatever those needs may be, try to address whatever those particular needs may be. And then, so say they do a specific research project or several cycles of quality improvement studies with their pod of practices, and one practice may then drop out, take some time off, another practice may replace it, And so they're always working, say, with 8 or 10 practices at any given time. And we can go to the next slide. So what these folks do is they collaborate with investigators and clinicians and practice staff to do research and quality improvement. They serve as liaisons between PBRN practices, investigators, and the resources that the PBRN can bring to practices. They also act as study recruiters and research assistants, pilot study facilitators, protocol trainers. They prepare IRB applications. So they wear a lot of hats and do a lot of things. But one of the things that was stressed to us, we went out and got training in Oklahoma from the people who originated this just last month, is that these people become almost like a staff member in these practices. They become, when it really works well, they gain the trust of the practice, and as they say, they can go in the back door of the practice without knocking. So they really become a valuable and valued member of the practice. And so because of that, they get to know the people in the practice, they understand the practice, and they can be of real value and real help to that practice, addressing issues that are important to the practice, whether they're problems at the front desk with communication or labs not getting into charts in a timely manner, quality improvement issues, or whatever they may be, holding staff meetings on a regular basis. These people are relied upon to do all kinds of things, and they get so much buy-in and so much investment and social capital build up that they then are in a very good position to recruit those practices into practice-based research studies. So let's go back one. Go forward. One more. There we go. So what I'm kind of have begun to think about a little bit is that these practice enhancement assistants and the way that practice-based research networks are developing may actually be signifying kind of a shift in networks. We saw that mission statement at the bottom of that slide from the Oklahoma PBRN. And what they've really moved away from, I think, is the traditional laboratory model of PBRNs. And this is from an article on PBRNs that by some experienced authors who say that the PBRN is the basic laboratory for primary care research. That's sort of been our mantra in practice-based research for a long time. PBRNs are the laboratory, community-based laboratories for doing clinical research in communities. And that's really how we've sort of sold our services to NIH and to funders, is this is the way to access practices and patients, community-based patients. And that's absolutely true. It is. But there's more of a practice-centered model, I would call it, that's emerging. And that is that in order to engage practices in research, we also have to serve as a resource for practices. We need to help practices and meet them where they're at and meet their needs. And by doing that, then, we can play an important role in helping those practices deliver health care and engage them in research at the same time. So PBRNs are beginning to take on a new responsibility for accessing resources for their practices rather than just simply engaging them in research. So I think a lot of this has been brought about because of changes in the practice environment that I'm sure most of you are aware of. There's been, in recent years, an increased emphasis on productivity, RVUs. Because of that, less time for practice-based research. Practices are experiencing very rapid changes in the healthcare environment, having to respond to those changes, creating greater organizational stress. And there are a lot of community-based practices, especially in this region, have been acquired by health systems. So they've gone through a great deal of change. And this makes it difficult for practices who used to be independent and make their own decisions about what they wanted to do and how they wanted to spend their time. They now have practice managers who have bosses in healthcare systems who make those kinds of decisions about how clinicians and practice staff spend their time. So things have changed a lot. And so by necessity, I think it's important that we begin to help practices meet their needs and, as PBRN leaders, give more back to practices in return for their investment in practice-based research. So there are new issues that PBRNs, I think, really must address if we want to continue to be successful moving forward as the health system continues to change very rapidly. Okay. So what we've done here locally is we've developed, at least for part of our PBRN work, a meta-network model. So we have this model, the outside oval or circle is our large research association of practices, which is really kind of an umbrella network for primary care practices and primary care networks. And within that, under that umbrella, we have a number of different networks. We actually have 6 of them. I just put 5 here. So say one of these is the Cleveland Clinic Practice-Based Research Network. One are our UH practices that form a PBRN. One is our residency. One is the Safety Net Providers Network. And the other is, say, the Metro Health practices that are forming a PBRN. So they all can function independently as PBRNs and really maximize the benefits within their own health systems for doing research and meet the needs of their own health systems by doing studies and quality improvement work that's specific to their health systems. But they also work across one another, across these networks, these sub-networks, really very seamlessly because they've done that for many years, about 15 years. And so our larger studies that cut across all the practices, such as some of our cancer prevention work, these sub-networks are working together really very seamlessly. So what we're doing then is we're also deploying practice enhancement associates, and we have now 3 of these individuals who are pretty new and who are being trained and being prepared and slowly moving out now to work with these sub-networks to help them really do the things that we saw on those previous slides to bring value to those practices in the PBRNs and to really maximize the amount of research potential that those practices and networks have. So these are the networks that we have locally. So there are 13 ovals in addition to this shared resource, which I'll tell you a little bit about later. But I'll just go through this very quickly. We have a dermatology PBRN, a pediatrics network, a very dynamic dental network that's done some really interesting cancer prevention work. And then this group here, from here down, are our primary care practices that were kind of displayed on the slide before. So we have independent practices that are coming together because actually we're finding independent practices are now almost becoming an endangered species of sorts, and they have their own particular sets of issues that they want to talk about with other independent practices. So they've formed a sub-network. Our Safety Net Providers Network, our university hospitals affiliated practices, our Cleveland Clinic, our Metro Health, community health centers, and our residency network, all in primary care, family medicine for the most part, and internal medicine, community oncology, a really exciting new nurse practitioners network that is getting a tremendous response from the nurse practitioners in the region, and a renal dietitians network that's being coordinated out of Metro Health that is a little bit on hold right now. All the other networks are functional networks. So now I'll move quickly then into the generation of research ideas within practice-based research networks. So as I talked about a little bit earlier, practice is, of course, a very inspiring place for clinicians to get ideas about research. So research ideas are generated in practice by academics, of course. Content experts come together in practice-based research meetings and talk about specific interests they have. They may actually come from the outside, not know anything about practice-based research, but want to access those practices and those patients to do research. There are really dynamic group processes that happen oftentimes in convocations, which is the name that's often given to PBRN annual meetings, whereby all of these different groups really come together and tap into these research ideas, and the clinicians can inform one part, the content experts the other, the academicians with research methods expertise another aspect of it, and really move things forward. Funding agencies are also, of course, very inspiring for getting research ideas, as we all know. So they're actually very interested in practice-based research networks, and are targeting RFAs now more and more to PBRNs, which is gratifying to see. So there's this dynamic in practice-based research between top-down and bottom-up, top-down being academic health center-based investigators that come with specific research ideas or even funded projects or wanting to write a grant for the network and having a very specific line of inquiry that they're following, that they want to engage the network in, and community-based clinicians who generate from practice their own ideas but may not have funding, have ideas and a passion, and are invested in the network and want to develop, say, small studies, pilot studies, observational studies, and descriptive studies that then can offer and inspire the development of a successful research proposal and support that. So within, I think, every network, there's this dynamic, whether it be top-down, bottom-up. Typically, they are a combination of both, which some have called a whole systems approach. And every network seems to find its right balance. If it's too top-down, the clinicians simply don't find a reason to be a part of it. If it's really bottom-up, the investigators don't see value in it because they have to get their research funded in order to continue doing what they're doing. So it's an interesting dynamic in different networks. So it's kind of a balancing act, and the leaders of the network need to apply some skill in working these things out in networks. So the next stage after ideas are identified is simply to design and refine projects. And we oftentimes break then into small transdisciplinary groups in the PBRNs. Those who are most interested in this particular issue, a group of clinicians and academics, content experts, who begin meeting on a regular basis to design and develop a research project. So everyone's expertise is valued and important, and I can't stress enough in practice-based research, as in all clinical research, the importance of pilot testing methods very thoroughly. When you have really heterogeneous practices in different health systems and independent practices, health system-based practices, et cetera, that may be engaged, you have all kinds of different systems and all kinds of different things can go wrong or be lost in translation, so pilot testing is very important. So I touched on this a little bit last week, but I wanted to go into a little bit more. Why do clinicians participate, and how do you engage clinicians? And I had this slide up last week, so I won't talk much about it, but it's about curiosity and professional growth, to share their ideas. Some want to acquire research skills, but pretty far down on the list is stipends and compensation for practice-based research. Clinicians are not typically doing this because the money's so good. There's not much money in this. They're doing it because they want to make a contribution and grow professionally, although we do try to provide stipends and compensation to them when we can. And that's an important thing to do. So these are a few different quotes from last week. This was an interesting quote from someone in a national network. My professional life isn't only about seeing sick kids, old people, many medical problems in nursing homes, and patients set on a path of self-destruction. It's about being able to ask a question about a medical problem and arriving at a conclusion by doing a study with our peers. It's avoiding burnout while expanding our horizons and helping patients. So this individual was really relying on the PBRN to help them avoid burnout and to stay kind of fresh and excited about clinical practice. Another clinician said, discovery occurs in settings where there's an alert, observant, and creative mind at work. These are the qualities supported in the PBRN. So these are the kinds of qualities that clinicians can also develop by interacting with investigators and content experts and other clinicians through a PBRN. So how do you make it worth their time, and how do you really respect clinicians' participation? I think it's really essential, if you're going to be a PBRN leader, that you really get it that the clinicians are full partners in the network, and there's really no network without the clinicians. And as a routine part of doing practice-based research, it has to be developing bottom-up studies. We do this all the time. It's just part of what happens in practice-based research. Small networks may choose a bottom-up study and then a top-down study because they don't have the resources. But our Ps, for example, Josh and Michelle and Dina, myself and Kurt, are always participating in the development of bottom-up studies. And then, of course, getting their input on patient recruitment, data collection methods, implementation, et cetera, places where they really have great expertise. And then next is to be sure to feed back the results to practices and involve the clinicians in the interpretation of the findings, which is incredibly important and extremely valuable in writing papers, of course, to get the perspective of the people who were in those practices when the data was collected. Acknowledge them in publications and offer opportunities for authorship, and there are specific ways to do that. I'll be happy to share that with you if you're interested. And then where you can, collect data using research assistants and research nurses rather than put the burden on the practice or the practice staff, and certainly where you can, not on the clinicians. Clinicians just don't have time these days to collect data the way they used to. So what we really try to do is use other people to collect the data in the practice. And then reimburse them for study-related work, the time that they do spend. And if what you're going to do is, over an extended period of time, access their patients or their practice to study it, provide them with some kind of stipend for that as well. And then provide CME whenever possible to clinicians. So those are some ways to make it worth their while. This is just an example of a feedback report in a study that we did where just an example of hemoglobin A1C level. So we have the practice aggregate level for the clinicians who contributed data in the practice versus all of the other sites that participated in the study. So a practice can see, okay, these are confidential reports, by the way, given to the practices. And then sometimes we had a third bar there that shows the individual clinician. So we have clinician confidential reports where they see themselves, they see their practice, and they see the aggregate whole. So these are just kind of nice peer comparison feedback that they enjoy getting and value. So you want to just kind of wring every bit of value you can out of the findings in the network and reflect that back to the practices because they really do get a lot out of it. So challenges in starting a PBRN. Funding is certainly a challenge, and we saw, as I talked about before, the infrastructure costs that networks can face. So how do you start a network with very little funding? Doing it on a shoestring is typically the way it begins, but it continues oftentimes to be a recurring issue that comes up for PBRNs over time. Practice recruitment is also a challenge. Clinician autonomy isn't what it used to be, so now we'll talk about this, I think, next week or the week after, about our kind of multi-stage process for recruiting within health systems and how we go about doing that. And then there are, of course, human subject protections issues. Getting clinicians to do CITI training can be incredibly difficult. And, of course, IRB applications can be time-consuming, and you run the risk of kind of losing your audience a little bit when that process is really drawn out in PBRNs. So these issues about the need for infrastructure support was recognized a number of years ago by AHRQ in one of their RFAs. For all of us PBRN leaders, did a really nice service in putting this in writing and just saying, you know, what we observe in PBRNs is that there's really a lack of support by funders for core activities. There's limited bridge funding between grants, and there are minimal staff resources because of this for networks. And so there's lots of volunteerism and support and cooperation, but that leads to burnout as well, and people just can't be put upon endlessly to volunteer their time. So what has begun to happen here recently, fortunately, are by different mechanisms, some systematic support for practice-based research. This has occurred across the country. Now I believe there are 38 clinical and translational science awards that have been awarded through the NIH Roadmap program, and I think almost